Hello, everyone, and thanks for tuning into this podcast. My name is Dr. Lacey Chetcuti. I am a research fellow at Stanford University School of Medicine. And on behalf of the authorship and the NET Development Project team, I'm excited to share with you our manuscript entitled Quantifying Neurobehavioral Profiles Across Neurodevelopmental Genetic Syndromes and Idiopathic Neurodevelopmental Disorders that will be published in a forthcoming issue of Developmental Medicine and Child Neurology. So firstly, I just wanted to acknowledge the funding sources for this study. For some more information on our funding sources and also our conflicts of interest, I refer you to our manuscript. So jumping straight into the introduction, so detailed characterization of the clinical features and natural history of neurodevelopmental genetic syndromes is essential for patients, clinicians, researchers, and policymakers alike. Such characterization provides valuable insights into the distinctive developmental strengths and weaknesses associated with each neurodevelopmental genetic syndrome and individual patient. This includes understanding cognitive, behavioral, and functional patterns, changes in skill development, cognitive profiles, and impacts on quality of life. This information is crucial for guiding the provision of treatment and also for the development of clinical guidelines and for identifying specific domains of functioning that are relevant to consider in future research and clinical trials. However, existing clinical measures have limitations in that they typically rely on in-person evaluations. They were not specifically designed for use in neurodevelopmental genetic syndromes and may not be suitable for those who are more severely affected. Additionally, these measures often require extensive testing batteries to adequately cover relevant neurobehavioral domains, which can lead to fatigue. Addressing these limitations is crucial for improving the accuracy, relevance, and applicability of clinical assessments for individuals with neurodevelopmental genetic syndromes. Therefore, our group has utilised recommended measurement development frameworks and collaborated closely with clinician scientists, caregivers, and patient stakeholders from various neurodevelopmental genetic syndromes and idiopathic neurodevelopmental disorders to develop and validate a novel online administered neurobehavioral evaluation tool, or the NET. This tool includes 11 informant report survey scales and 47 subscales, offering detailed characterization of key neurobehavioral domains. So in particular, 6 of those 11 NET scales focus on psychiatric symptoms, including anxiety, ADHD, mood, restricted repetitive behavior, challenging behavior, and sleep problems. The remaining 5 NET scales look at patient skills and functioning in areas of social communication and interaction, executive functioning, daily living skills, motor skills, and quality of life. The purpose of the present study was to evaluate the scale and retest reliability of the NET scales and subscales, and to also examine the profile of differences between clinical groups, including the specificity of those differences. So in particular, do we still see differences when we account for estimated cognitive level, speech level, and the presence of autism spectrum disorder? So our participants comprised 498 individuals aged between 3 and 45 years old, and these participants were spread across 7 different groups. So we had participants with P10 or P10 hematoma tumor syndrome, or PHTS. We had participants with SYNGAP1 and also participants with Milan syndrome or with NFIX mutation. We also had a mixed group of other neurodevelopmental genetic syndromes, and we also had 2 control samples. So the first control sample comprised siblings of individuals with neurodevelopmental genetic syndromes, and our second control sample included unrelated controls. We also had a sample of individuals with idiopathic neurodevelopmental disorders, so this being individuals without a genetic syndrome but with a neurodevelopmental disorder diagnosis, including autism, ADHD, mood or anxiety disorders. Data from this study were collected between October 2021 and May 2024 from participants in the United States as well as 8 other countries. Parents and caregiver informants completed an online survey that contained a demographic and clinical information questionnaire, followed by each of the NET survey scales. and they completed the NET survey scales at 3 time points. So at study entry or baseline, and then 1 month after that, and then 4 months after that. And we calculated NET subscale scores based on results from a previous factor analytic investigation that we conducted, and those being reflecting average scores for each of the items. So in terms of results, first we were interested in scale reliability or internal consistency, and we calculated this using the Cronbach's alpha coefficient. We found that all of the NET scale scores exhibited good to excellent scale reliability, and that reliability was at least adequate for 41 of the 47 NET subscales. Those 6 subscales with less than adequate internal consistency were those that only had a few items. And in each case, though, the corrected item total correlations were above the recommended minimum. So we tested retest reproducibility over a 1-month follow-up period and found that this was good to excellent across all subscales, except for one of the quality of life subscales, which was fair. And then we tested stability over our 4-month follow-up period, and we found that stability was fair to excellent for all of the NET subscales. Next, we explored group differences and explored the profile of neurobehavioral functioning relative to a control sample of neurotypical individuals. So what I've shown here is a heat map that depicts the strength of deviations from neurotypical expectation. So effectively, the darker the red color, the more deviation or the more difficulty is experienced relative to neurotypical peers. So on the left, we have those symptom scales of the NET, and then on the right-hand side, we have the skills and functioning scales. And I'm going to go through and briefly summarize what we found for each of the groups individually. So firstly, for individuals with PHTS, we found that they exhibited higher levels of symptoms related to distraction and also higher levels of restricted interests within the restricted repetitive behavior scale. In terms of motor skills, their performance was notably low, with extremely low scores in speed, strength, stamina, and low to very low scores in basic motor skills and also fine motor skills. We found that they also had challenges with processing speed and that their skills in basic social communication, perspective taking, and forming relationships were also in the low range. However, their social motivation was intact, so it was relatively equivalent to our neurotypical control group. Lastly, in terms of quality of life, we found that scores were for family dynamics and physical and mental health were in the lower range. Next, for participants with Milan syndrome, we found that they exhibited notably high levels of physiological and panic anxiety symptoms, which distinguished them from our other clinical groups. We found that they also demonstrated elevated symptoms across specific domains, including ADHD, restricted repetitive behaviours, and challenging behaviours. With regards to motor skills, we found that individuals with Milan syndrome also showed extremely low proficiency in basic motor skills, speed, strength, and stamina, and processing speed, alongside low to very low scores in sequencing and daily living skills. Within the social communication and interaction domain, we found that these participants showed impairment primarily in perspective taking, which fell within the very low range. And then finally, in terms of their quality of life, we found that family dynamics and physical and mental health were low and very low. Next, for participants with SYNGAP1, we found very high to extremely high levels of symptoms across several areas, particularly in elopement, conduct problems, and self-injury. We also found high aggression and restless sleep. In terms of skills and functioning, we found that the SYNGAP1 group displayed extremely low levels across multiple sets of subscales, including social communication and interaction, daily living skills, and motor skills. Additionally, their scores were notably low in processing speed and relationships. Our group of other neurodevelopmental genetic syndromes showed notably high scores in elopement and self-injury, as well as elevated levels across all restricted and repetitive behaviour scales. They also exhibited tendencies towards distraction, disorganisation, and restless sleep. And they also reported high levels of physiological panic and sensory anxiety symptoms. In terms of skills and functioning, we found that this group had extremely low scores across all motor skills scales, processing speed, and perspective taking. And their skills in basic social communication, forming relationships, sequencing, and daily living were also identified as low or very low. Furthermore, they reported very low scores in family dynamics and physical and mental health quality of life. And then lastly, reflecting the relatively milder nature of the idiopathic neurodevelopmental disorder group, they primarily reported high levels of distraction symptoms. No other symptom or skill functioning scale deviated more than 1.5 standard deviations from the mean that we established in the neurotypical population. So just to summarize, our study demonstrates the potential value of the NET survey scales while identifying significant syndrome-specific neurobehavioral patterns. Understanding these patterns allows us to design more effective psychosocial and behavioral treatments tailored to neurodevelopmental genetic syndromes and select the most relevant outcome domains to focus on in future research and clinical practice. These findings may also help educate caregivers and also treatment providers about the most common areas of difficulty associated with these syndromes. This study is also not without limitation. So first and foremost, we focus our results on a single measurement modality. So all of our data were derived from the NET, which is a questionnaire measure and reported by caregivers. Future work that uses multiple assessment modalities, including subjective and objective or performance-based behavioral and cognitive measures, and multiple informants for questionnaire-based information would be valuable in ensuring our precision of measurement and ensuring that we're obtaining an accurate picture of neurobehavioral function, and also assist in reducing biases associated with sampling and informants. Next, this sample comprised a relatively modest sample size and also was conducted over a relatively short time frame. Studies with longer follow-up periods will be needed to more clearly identify unique longitudinal patterns, including any syndrome-specific developmental trajectories, while larger sample sizes will also ensure the generalizability of findings. Lastly, the study was limited to capturing the neurobehavioral domains that were included in the NET survey scales. So while the NET scales were developed with stakeholder input to identify the most important domains and content areas, it's also possible that key symptoms, skills, or functional areas are not being captured by the NET. Therefore, future work could evaluate whether scale expansion would be potentially useful for researchers and clinicians. So thank you so much for tuning in. I just wanted to acknowledge the contributions of all the participants involved in this study, without whom this research would not be possible. And also wanted to extend our appreciation to our recruitment partners. Thank you very much.